Okay, so I went back to where I had started kind of rushing. I went through the care continuum for substance abuse. So, in the implementation, the brief interventions, you'll see frames. I don't actually end up asking you anything on that, but if you want to learn more about it, it's on page 425. Counseling is needed for these patients, so their motivation is enhanced and denial broken, and we work on relapse prevention. Relapse prevention, there's a lot that goes into that because we have different models that can help patients with relapse. The 12-step program being one of the primary ones that many places use, but there's others as well. And then there's medications we can use to help the patient to not relapse as well, which is psychobiological interventions, pharmacological. We're going to go into some meds in just a minute. Health teaching and health promotion. Genetic vulnerability accounts for 40 to 60% of individuals at risk. So that's really important to remember that this is a genetic disease. It can be part of the family system, so we have to try to guard against that. So medications that are used with substance use disorders. So when the patient, so the first one is going to be disulfiram. This is Antabuse. So what this does is when the patient takes their Antabuse in the morning, when they're feeling pretty good, and by the evening time when they're feeling like they want to drink again, they can say to themselves, oh, I took my Antabuse today, I can't drink. Because what will happen if they do is that it will make the patient have a toxic reaction. What actually happens is the Antabuse prevents the alcohol, the acetylcholine breakdown happen, which ends up being toxic to the body. And just makes the body feel very, very uncomfortable. So you can see vomiting, headache, sweating, flushed skin, respiratory difficulties, confusion. But it does have to be taken every day. So as soon as a patient starts thinking, well, maybe I'd be able to handle one drink, and they quit taking the Antabuse, then I think it's 2 or 3 days that they have to be off of it before they won't have any kind of reaction from it anymore. So that's the only problem, is that they have to take it every day. And if they don't take it every day, then they can start, using again. Phenobarbital is a medication that we use to help get the patients off of alcohol or benzodiazepines. It is a barbiturate. It can produce sedation, it prevents seizures, and decrease heart rate and BP. So it just chills the patient out and takes away a lot of them really uncomfortable symptoms of the withdrawal. The nice thing about it too, though, is that it does prevent seizures. So the patients that are going through benzo or alcohol withdrawal, if they're on phenobarbital, typically don't need to be on any other kind of seizure preventative. Naltrexone, you're going to hear this used a couple different ways. We have Vivitrol, we have Revia. Vivitrol is a shot. It lasts 30 days. Revia is a pill they take every day. We also have nasal Narcan. So this is all kind of the same drug. So if you heard about your patient getting Narcan to reverse opiates. So this prevents opiates from binding to opiate receptors. The one thing about using this is that a patient has to be off of any kind of opiates typically for 10 days before we'll give them either one of these, because we can send them into withdrawal symptoms if we don't. Patients use this for, obviously, first, if they're addicted to opiates, then the opiates won't be able to bind, therefore they won't get high from the opiates that they take. But they also use naltrexone as a, anti-craving medication for things like alcohol. They've found with research that naltrexone actually works in the brain to make the patient feel like they don't really want to drink. So it takes away, so we'll call it anti-craving medication. This is why. Okay. Clonidine or Cataprast. This is a antihypertensive medication that has been found to assist with opiate withdrawal. If you ask any of our patients about it, and down in Brighton, let's say, they would tell you that it doesn't work all that well because it doesn't work nearly the way that Suboxone will work. But they have found that patients with opiate withdrawal can benefit from Cataprast. So you want to know the signs of opiate withdrawal. tachycardia, fever, runny nose, diarrhea, sweating, nausea, vomiting, irritability, stomach cramps, shivering, large pupils, weakness, and insomnia. So many times when I'm assessing my patients and they're telling me their symptoms, I'll say, let me look at your eyes, because I can tell from them really large pupils that the patient is truly in withdrawal. If they have tiny little pinpoint pupils, the reality is they're probably not in too much of a withdrawal, but I still believe what the patient tells me. But I have these objective signs I can look at as well. Buprenorphine, which is Subutex or Suboxone. Suboxone is the one that I use primarily. This is used for withdrawal of opiates. It can be short or longer duration. This is in question in many treatment facilities. So in the treatment facility I work in, we get the patient off of the heroin or the opiates with the Suboxone, and then we get them off the Suboxone within a couple days. We don't do any long-term treatment of Suboxone where I work, and a lot of places are finding that Suboxone that was prescribed long-term was not actually a great idea. It's usually given as a film. This, with our patients, we must ask them when their last use was and make sure they're being honest with us, because if they've used in the last 12 hours and we give them Suboxone, we send them into intense withdrawal, which is really, really uncomfortable compared to whatever they were feeling, the discomfort they were feeling before. So we want to make sure that we tell them that how important it is for them to be honest with us about that. So you have alcoholics or different things that we can offer to our patients for community support. Alcoholics Anonymous, Alateen, Al-Anon, Nar-Anon, Gamblers Anonymous. So your Al-Anon is for the person who loves the person that is struggling with alcoholism. But truly it ends up really being more for codependence on other people for whatever it is. Who is being put in front of your own self and learning how to not do that. Alateen for the teenagers that are growing up in families that have alcoholism problems. Nar-Anon, that's the same thing as Al-Anon, just for narcotics. Gamblers Anonymous. And then if you click this link down here that I've provided, I can't even get my mouse to go there, this right here, you will find all of the Genesee County AA meetings listed on there. That's a nice resource for us to have, especially in this area, so we can direct our patients to this, and it's good to be familiar with it. So now I'm going to actually go back to the Faces of Meth, and here we go. And I'm just going to, oh, I got to do this, and show you guys right from here. So Faces of Meth, it's going to take it a second to load. Maybe it's not going to load. If it doesn't, then again, I'm just going to have to ask you guys to please view this if I can't get it to pull up here. My Internet Explorer just froze. Big bummer. This obviously did not want me to show this to you. Yeah, it didn't. So, okay, please, please, please watch these, okay, or go through it. It takes literally 2 minutes to look through them. It's not a presentation or anything. It just shows the progression of what happens from, and it shows the amount of time. So it'll show like 3 months, 7 months, couple years. You'll be surprised at how many years people age just in their short time of using. So I guess that's it. Again, please go ahead and view those.